as I mentioned, I'm in Cambridge, and two speakers joining us today, one from Tokyo and one from London, and I'll just briefly introduce them. So Haruka Sakamoto is a primary care doctor, and she is an assistant professor at Keio University. She has a master's in public health from Harvard. She worked for several years at the Ministry of Health, Labour and Welfare in Japan in the International Cooperation Department, which means that she was dealing with WHO, G7 and so on. She also is a researcher currently at the University of Tokyo, a consultant to WHO's regional office and to the Gates Foundation's Tokyo office. And her research focuses on strengthening healthcare systems. And then our second speaker will be Sarah Reed, who is a senior fellow in policy and research at the Nuffield Trust. And before that, she was a fellow at the Health Foundation. She's also worked in policy analysis for the NHS clinical commissioners. And she was previously also program director at the Institute for Clinical and Economic Review in Massachusetts. So without further ado, here's the timeline. We'll run on maybe a little bit after 1. We'll see how it goes, but we'll certainly aim to wrap up by 1:15. Right, and I will now pass over to Dr. Haruka Sakamoto to start us off.
Okay, can you see my presentation slide?
Yep.
Okay. Hi, hello everyone. Thank you very much for inviting me today. It is my great pleasure to be here today. So thank you very much for the kind introduction. My name is Haruka Sakamoto, Assistant Professor at the Department of Health Policy and Management at Keio University. So today, I'd like to talk about the situation of the COVID-19 in Japan, as well as how the Japanese healthcare system has responded to the COVID-19, especially why the healthcare system in Japan is under pressure, even though the number of COVID-19 cases is relatively low compared to other countries. Okay. First, I'd like to talk about the situation of COVID-19 in Japan. Here is the number of cases of COVID-19 in Japan. There have been a total of 5 epidemic waves since last year. The most recent one was the largest, and then it was in late July this year, just as Japan was hosting the Olympics, when the infection spread rapidly, mainly due to the spread of the Delta variant. This wave is now coming to an end. This is a graph showing the number of COVID-19 cases among G7 countries. The gray background is countries other than Japan, and the black line is the number of infected people in Japan. So looking at this graph, the number of infected people in Japan has been kept low compared to other G7 countries until the 4th wave. But in the latest 5th wave, the number of infected people is at the same level as other countries, or even higher than some other countries. I think this is mainly due to the epidemic of the Delta variant, as mentioned earlier, and then also due to the difference in the timing of the vaccination campaign. I think in the United States and some European countries, the vaccination for the COVID-19 started from the end of last year to the beginning of this year. However, in Japan, vaccination for the general public, excluding the medical personnel, did not start until May. Next, I'd like to look at the number of deaths due to the COVID-19. This is a graph showing the cumulative number of deaths due to COVID-19 among G7 countries. Japan, shown in the purple line at the bottom, has the lowest cumulative death toll among the G7 countries. Or since the number of deaths in the United States is quite high, here is a comparison among G7 countries, excluding the United States. Same in the previous slide, the purple line at the bottom is Japan. Again, you can see that Japan has been able to keep the number of deaths relatively low. This figure shows the cumulative number of deaths, but when we compare the number of deaths per million population, this number in Japan is also relatively low compared to other countries. On the other hand, it has been pointed out that Japan has a higher number of this, especially in the Asian regions, and then this is true. However, it should be noted that an aging rate, which is the biggest risk factor for the COVID-19 to become severe, differs greatly when comparing the Asian countries. Here is a chart showing the aging rate in Japan, Western countries, and then some Asian countries. As many of you may already know, Japan is the most aged country in the world, with about 30% of the total population over 65 years old. Even in South Korea, which is the second most aged country in Asia after Japan, the percentage is about half, or about 15%. And this figure is the current status of excess deaths in each country from The Economist magazine. This does not reflect the impact of the most recent fifth wave of infection in Japan, which was the largest epidemic, but Japan has not seen any significant excess deaths so far. Also, the total number of deaths increased in many countries last year. But in Japan, on the contrary, the total number of deaths due to all causes decreased in 2020 compared to the previous years. It is mainly due to a decrease in deaths from other infectious diseases, such as seasonal influenza, as a result of thorough countermeasures against the pandemic. In summary, at least in terms of the comparative figures, we can say that Japan has been able to keep the number of deaths relatively low in spite of its high aging population. So this is a brief overview of the COVID-19 situation in Japan. And then next, I'd like to give a brief overview of the Japan's countermeasures against the COVID-19, mainly about testing, isolation, and then tracing, which WHO has repeatedly stated as the basics of infectious disease control. First, about testing, Japan has adopted the approach of cluster control. In this approach, when someone tests positive for COVID-19, close contacts are tested intensively. In other words, people with any symptoms, such as fever or cough, and then those in close contact with COVID-19 positive are the main testing target. On the other hand, mass screening for asymptomatic people, as seen in some countries, is not common in Japan. So in Japan, it is not common to allow anyone to be tested anytime, anywhere. Next, about for contact tracing. Unlike other countries in Asian region, there was a strong concern over the privacy issues, and then did not use any application gathering personal information about the infected and their close contact by the middle of June last year. Instead, the staff at the local public health center, I will explain the detail about the public health center later in my presentation slide, but staff at the local public health centers asked the infected individually over the phone call. In June last year, the Ministry of Health, Labor and Welfare introduced an application named COCOA for collecting contact information. In this application, Bluetooth is used to detect and record contact between users of this application. Okay, so in June last year, the Ministry of Health, Labor and Welfare introduced the application named COCOA for collecting contact information. In this application, Bluetooth is used to detect and then record contact between users of this application. It would notify users if he or she had close contact with COVID-19 positive. Users who are notified by the app is encouraged to stay isolated or consider seeking medical attention on their own. Still, this application only uses Bluetooth information and does not gather any personal information. Next, as for the isolation, patients with moderate or severe conditions are basically hospitalized, while patients with mild cases or those with no underlying disease and low risk of becoming seriously ill are generally isolated at home or in treatment facilities, such as hotels. It is recommended that patients do not leave their homes or treatment facilities for a certain period of time, but it is only a request, and then there is no penalty for failure to comply. In some countries, strict measures are used to check if the quarantined person is really in quarantine. However, in Japan, community-acquired infections, such strong measures are not introduced. In addition, while many Western countries have adopted the so-called lockdown, Japan has not adopted such a strict measures. For example, Tokyo is still under a state of emergencies, but there are still many people walking around the city and eating at restaurants and cafes. And some of you may have seen the current situation in Tokyo during the Olympics, and you may have felt that the atmosphere in the city, even under the state of emergency, the atmosphere is quite different from the so-called lockdown in the West. So in summary, it can be said that while Japan focuses on the testing and isolation priority for those with positive cases and the close contact, it does not take any coercive measures and then basically relies on the people's behavioral change to control infectious diseases. So next, I'd like to explain about the Japanese healthcare system, mainly the two major characteristics of our healthcare system. One is universal insurance system, and the other is uniform fee schedule. As to the universal insurance system, which was established in 1961, this system covers the entire population living in Japan and secure access to healthcare services at an affordable cost. Everyone, those who are aged above 20 years old, are required to pay a monthly insurance premium, while they can get healthcare services anytime with predetermined co-payment rate. Also about the uniform fee schedule, in order to ensure cost containment, Japan introduced the uniform fee schedule alongside the establishment of the universal health insurance system. So like most of the other European countries, the government of Japan determines the price of healthcare services, which are revised once every 2 years. These publicly defined fees apply to private healthcare facilities and are not limited only to public healthcare facilities, which means that the price of healthcare is exactly the same price between public and the private. The uniform fee schedule enables us to contain the total cost of healthcare, even though the majority of healthcare facilities in Japan are privately owned. So by combining the universal insurance scheme and the uniform fee schedule, Japan has secured access to healthcare services for all people, regardless of their socioeconomic status, while at the same time controlling the total healthcare expenditures. And in addition to our universal health insurance system and the uniform fee schedule, public health centers have also played an essential role in improving the health in Japan. To explain briefly, in Japan, preventive services and then public health services are provided by the public health centers, while medical services such as the treatment of disease are provided by the medical institutions. Preventive and then public health services provided by public health centers are basically funded by public funds such as tax, while medical services provided by medical institutions are provided within the framework of the aforementioned universal health insurance system. So for example, tuberculosis was one of the leading causes of death in Japan during the post-war period. All costs related to tuberculosis management, such as screening and treatment, are covered by public financing through taxation with no out-of-pocket payments to the patient. While public health centers have been in charge of the public health management of tuberculosis, including the mass screenings, healthcare facilities have also played an important role. So the individuals who have any symptom that indicate the possibility of tuberculosis infection, such as fever or cough, can access healthcare facilities at affordable cost thanks to the universal health insurance system. So by combining tax-based public financing and the universal insurance system, as well as public health centers and healthcare facilities, Japan was able to rapidly decrease the deaths by tuberculosis. So this combination of the system by public health centers and the medical institution was the same in the COVID-19. During our initial response to the COVID-19, public health centers played the central role in COVID-19 management, including the contact tracing and isolation management, and the public financing has covered all the costs for tests and treatment. In addition, thanks to the universal health insurance system, any person who had any symptom, whether it be fever or cough, had access to healthcare facilities without worrying about the cost. So from here on, I'd like to go a little deeper and see how the healthcare system has responded to the COVID-19 outbreak. In terms of the response, how to increase the number of hospital beds, and then how to secure medical personnel as the main issues. And then first, I'd like to look at the hospital beds. The first characteristics of the number of hospital beds in Japan is the overwhelmingly large number of hospital beds. Here is a comparison of the number of hospital beds in OECD countries. So the number of hospital beds per 100,000 people in Japan is 12.8, which is an outstandingly large number. This figure is 7.9 in Germany, 5.8 in France, and then 2.4 in the UK. In other words, Japan has nearly 5 times as many hospital beds as the UK. On the other hand, the number of beds for intensive care, which is essential for the treatment of the COVID-19 patient, is actually low in Japan compared to other countries. The number of ICU beds per 100,000 people in Germany, the country with the largest number of ICU beds, had 33.9, while that number in Japan was only 5.2, or about 1/6. Together with the previous slide, we can see that although Japan certainly has a large number of hospital beds per population, most of these beds are not for treatment of infectious diseases or acute patients, and are designated mainly for long-term care of the elderly, and there are a few acute care beds that can treat COVID-19 patients. Another characteristics of the hospital beds in Japan is that most of the medical institutions in Japan are privately owned. As of 2016, there are about 8,400 medical institutions in Japan, 80% of which are private, and the remaining 20% are public. Most public medical institutions are large hospitals, such as municipal hospitals, while the remaining 80% of private medical institutions are small and medium-sized hospitals and then clinics. Most of the medical institutions that can take care of the seriously ill patient are public medical institutions, while most of the private medical institutions are small and medium-sized that do not have beds for seriously ill patients or cannot provide advanced treatment for the infectious diseases. In fact, the percentage of hospitals that can accept COVID-19 patients is 70% in the public sector, while it is only 90% in the private sector. Although this figure is from the October last year, so the number of private institutions had probably increased somewhat. However, the fact that fewer private medical institutions accept inpatients with COVID-19 compared to the public institution is not simply a matter of criticism. One reason is that they are not equipped to treat patients with severe illness and infectious diseases. As you can easily imagine, especially if you are a healthcare professional, ICU care bed or infectious disease bed require various equipment, such as the ventilators. For example, it is necessary to completely separate the flow of the patient from the other patient when treating the infectious disease patient. However, it is not easy for medical institutions that have been treating mainly subacute to chronic patients to convert to such heavily equipped beds. These institutions often do not have specialists in infectious diseases, and then the forcibly accepting COVID-19 patients in these institutions may increase the risk of the nosocomial infections. There is also the issue of financial resources. During the COVID-19 epidemic, many medical institutions lost revenue because non-COVID-19 patients refrained from going to healthcare facilities and then hospitals postponed surgeries as much as possible. In terms of the hospital management, accepting COVID-19 patients would have resulted in a financial loss. In response, the government is taking measures such as subsidizing the financial resources, but financial issue still be a major reason for not accepting a COVID-19 patient for some medical institution. Also, it should be noted that private medical institutions that do not accept COVID-19 patients also played an important role during the COVID-19. The outpatient department or those facilities thus respond to the patient suspicious with the COVID-19 and then arrange for the transfer to the hospital if they are diagnosed positive. Also, as I mentioned at the beginning of my slide presentation, that excess mortality is low in Japan. And then another important point is that those private medical facilities provide the care of the patient other than the COVID-19. The exact statistics are not yet available, and this is just my personal impression, but I believe that this low excess mortality is partly due to the support of those medical institutions that do not accept the COVID-19 patient. The important thing is to find a balance of the care between the COVID-19 and the non-COVID-19. Also, when medical institutions that do not normally participate in intensive care and infectious disease treatment participate in the COVID-19 care, the following are important. The one is to ensure the quality of medical care, and the other is the safety of the medical personnel. The central and local government should provide appropriate financial resources and then a backup system with infectious disease specialists and other medical institutions familiar with seeing the infectious disease patient. However, as mentioned earlier, most of the medical institutions in Japan are privately owned, and it is indeed more difficult for the government to make a strong request in terms of the hospital beds capacity than to private facilities and public institutions. So considering the public health emergency may occur again in the future, it is necessary to consider appropriate governance over the private healthcare facilities. Another challenge of Japanese healthcare system is the inefficiency of the healthcare delivery system. On the left is a comparison of the number of hospital beds in each country. Japan has more than 8,000 medical institutions, making it the country with the most medical institutions in the world. Even the US, which has the second largest number of medical institutions, has about 6,000 medical institutions, which shows how many medical institutions Japan has. On the other hand, the right slide compares the number of physicians per 1,000 people among the G7 countries. On the far left, Japan has the lowest number of physicians per 1,000 people among the G7 countries. The number is at 2.5. In other words, physicians in Japan are dispersed among small and medium-sized medical institutions, which has led to the inefficiencies in the medical service delivery and has placed an excessive burden on the medical personnel. So during the COVID-19 pandemic, it has been pointed out that the inefficient aspect of the healthcare delivery system did not lead to the flexible system for accepting the COVID-19 patient. So even before the COVID-19, it was pointed out that inefficiency caused in publicly funded, privately provided system was a major characteristic of the Japanese healthcare system. To solve this situation, Japan launched the regional healthcare vision in 2014. Under this vision, each local government estimates the future demand for medical care in the region, and then how many hospital beds will be needed to meet this demand. And then reorganize hospital beds based on this estimate. Also, during this process, local governments are encouraged to clarify the roles of the both public and private medical institutions, the transportation system, and then coordination between hospitals. So COVID-19 occurred amid revitalizing this vision, but it is required to promote the reorganization of the hospital beds at regional level, functional differentiation, and strengthening the coordination system, taking into account of the impact due to the COVID-19. So this is a summary of my presentation slide. So the characteristics of the Japanese healthcare system are majority are privately owned. So it is sometimes difficult for the government to control over the governance. However, the private healthcare facilities, even they do not accept the COVID-19 patient, had played a very important role, especially for the manage the non-COVID-19 patient. So it is very important to the balance, to seeing the balance between the COVID-19 patient and not COVID-19 patient. Okay. So thank you very much. This is the end of my presentation slide. Thank you.
Right, thank you very much, Sakamoto Sensei. So let's hear now from Sarah Reed.
Great, thank you. I'm going to share my screen now. Hopefully you can see that now. Yeah, I was really struck by some of the similarities but real differences and where we're at with COVID-19. So hopefully that's something we can get into in the discussion. But yeah, thank you so much for having me today. My name is Sarah Reed. I'm a senior fellow at Nuffield Trust. And what I'm going to do is just briefly talk about how the UK has fared throughout the COVID-19 pandemic, and then get into a bit about, as Dr. Sakamoto did, what our health system response looked like, but then some of the lingering challenges and issues we're now having to face in our recovery. But before I do that, just to say a few words for those who might be less familiar about how the health system is designed and organized in England. And I'm saying England because each country within the UK has devolved powers or core responsibilities over their own health system. So what happens in England is slightly different than Wales, Northern Ireland, and Scotland. But I'll focus on England because that's where most of my examples come from, and that is where about 80% of the population of the UK lives. But just to explain briefly, so the English NHS is a free at the point of use health service. So anyone who's normally resident in England is entitled to free health care, and that includes hospital services, physician services, mental health services. The health services is funded through general taxation, which leads to a fairly centralized model of care and decision making within the country. This flow chart is slightly out of date. There's been a few changes to organizations throughout the pandemic, but it gives you a sense of how decisions and resources flow throughout the health system. But mostly just to emphasize that when it comes to healthcare, accountabilities really do sit centrally with the government. So Parliament has oversight, and then from there, the Secretary of Health and Social Care, and then most of the day-to-day running and operations of the NHS is accountable to an agency called NHS England and Improvement. And that kind of centralized coordinated approach is something that I think does come out and has impacted our COVID response, and which is something we could get into. And so when I speak about some of the health system response, a lot of that is coming, or those strategies are being set and the resources for them centrally. And also just to say, important, maybe an interesting distinction from Japan is that about 80% of all of England's health spending does go to public hospitals and providers. There is a private health sector in the NHS, but only about 7% of funding actually goes to private hospitals, or what we would consider private hospitals in the UK. And even though it is free at the point of use entitlement, there are about 10.5% of the population does have some form of voluntary health insurance, but that's mostly used to gain more rapid access to elective care or private accommodation and things in hospitals. But so moving on then, just to say a bit about England's record on COVID-19. And I think as Dr. Sakamoto got to, I think we're in a fairly unenviable position, at least relative to Japan in many regards. But we have had quite a high number of deaths from COVID-19 in our country. We've had so far the 8th highest number of COVID-19 deaths in the world. Latest data suggests we have about 7 million cases. This contrast with Japan looks just as stark even when you control for differences in population. There's of course a lot of challenges in comparing mortality and death across countries, but even when we look at things like excess mortality, which Dr. Sakamoto also pointed to, the UK is in a very different position than Japan, maybe a bit less different and stark with some of our other countries in the G7 at least, but there was at least, particularly around wave 1 and wave 2 of the pandemic, where the UK was experiencing consistently higher number of deaths than it normally would in a regular year. And another thing I just want to point out to that has been a real challenge and something that will impact our recovery from the pandemic is that COVID-19 has really exacerbated or magnified inequalities that we had going into the crisis. So when we look at who has died from COVID-19, that doesn't look equally across the country. We have found data that's emerged has shown that those who live in the poorest parts of the country are twice as likely to die than those who live in the most affluent areas. And that's a trend that is not, unsurprisingly, sadly, but isn't different with COVID-19. That's a trend, as you can see in the chart here on the left, that follows lots of different forms of mortality. And this is a real challenge that we're going to have to now address and think about with recovery, is how can we address some of these underlying causes of inequalities and prevent them from getting even worse. Where there has been perhaps a better picture to our story to tell is around vaccination. So relatively speaking, the UK has been very privileged in its access to vaccines and has been able to deploy them fairly quickly. We're now at the point of having vaccinated about 65% of our population. And that number, of course, is higher when you exclude young children and those who are not yet eligible for the vaccine. But I also wanted to say a bit before we get into what the NHS did and how it responded and some of the challenges it now faces. I think it's worth just touching on some of our broader COVID policy and how that sits in contrast to Japan's and how that might be playing out in some of those trends I've just described. But I think it is a really tricky one because there's no obvious answer to point to about why the UK's data looks so different from Japan's at this point. But just to give some context to that conversation, we have had a really large scale approach to test, trace, and isolate in the UK. It's where the government has spent a lot of resources. So as of May of this year, we've already spent about £11 billion on our test, trace, and isolate strategy. But even with that high investment, it has had some challenges in its performance and its ability to really curb transmission. So in its first year since coming online, it ended up only reaching about 70% of cases. So that means about 13% of cases and 18% of close contacts weren't actually reached through the system. So that's below what scientific evidence suggests is needed to have an effective test and trace system. And there's been some real concerns around its capacity at key points of the pandemic, which has meant that it wasn't living up to its own standards of being able to provide results within 24 hours or challenges around people not being able to get tests when they need it. We have had an NHS app as a similar model maybe to Japan, where compliance wasn't mandatory, but that was another tool we had to help contact tracing and notifying people when they need to isolate. But where a key area where things really did break down was around isolation. Even though there was a legal mandate or requirement for people to self-isolate when they've tested positive or been exposed or have symptoms, we know from survey data taken throughout the pandemic that compliance was fairly low. Some surveys suggesting that about a quarter of people experiencing symptoms, that only about a quarter of people who had symptoms requested a test, and only about half isolated when they had to. So that is a real limitation of this system and could be one of the drivers of high transmission rates. And in contrast as well, we have had periods of extended lockdowns. So those of you living in the UK, I don't need to remind you. And it's really only now where we're moving into a phase where we are reducing a lot of our social distancing measures. But you can see here, we have spent a lot of the pandemic in some form of formal lockdown. So what did the health system do to respond? I think, like Japan, there was a need to really build extra surge capacity to be able to deal with the demand that COVID-19 is creating, but also to do as best as we could to balance both COVID and non-COVID care. And some of these things might look similar in Japan and in other countries where you may be from, but some of the things the NHS did was quickly work to recruit and re-enroll inactive health personnel and volunteers to be able to have as much staff as possible. That included kind of changing our approach to registration, onboarding, and just doing things a lot more quickly to be able to have people in post. We formed different partnerships with sectors like the private sector, borrowing staff from private hospitals to be able to build as much capacity for the public side as possible. We were redistributing staff and moving them into new roles. So moving more staff into ICU, and also thinking about primary and community care, where there was expanded roles there to manage as much COVID as we could outside of hospital. And now with the vaccine rollout, kind of expanding those roles to be continue to be part of the pandemic effort. Other things we did to kind of protect bed capacity. So similarly, moving patients into private hospitals or using their beds and equipment where we didn't have enough in the NHS, converting existing wards into ICU units. We've actually built some new field hospitals that were designed to see less severe cases of COVID or to keep more routine care going. We also had a massive shift towards telehealth and digital first models of care to be able to protect as much access as possible. But even with all those interventions, a lot of which we know lots of countries are doing, we still had a real challenge in the UK and in England in balancing both COVID and non-COVID care. And this is when we talk about recovery, this is the challenge we're now faced with. So COVID, of course, involved massive trade-offs, even with those interventions to try to make those judgments and keep as much care going. But there have been significant issues or challenges in maintaining that access. So what you'll see here in these charts is that, in the first wave, we saw a huge drop off in activity. That was because a lot of care had to be formally canceled and deferred as hospitals were busy and more resources were being diverted towards COVID-19, but also because a lot of fewer patients were coming forward for care than they normally would because of maybe fears around pandemic and rules around lockdowns and self-isolation. And while a lot of effort has been put in place and kind of staff are doing everything they can to get back to normal and restore activity as quickly as possible, it's happened at a much slower rate than it initially fell. So what we're seeing is the pandemic is kind of accelerating this challenge we've had with wait times, with more patients waiting for longer periods for care. And in June of this year, the wait list, the number of patients waiting for hospital care, reached its highest number on record with about 5.4 million patients. But a point I want to emphasize here is that that challenge with waits is something that was only accelerated because of pandemic, but wasn't caused by the pandemic. As you can see from this chart here on the right, that waiting lists had been growing before we ever even knew what COVID-19 was. And that's more of a reflection of kind of structural challenges we've had in the health system to keep up with the demand that's being placed on it. And that's something that's only gotten worse during the pandemic and something we now need to confront with our recovery. So just to briefly touch on before we get into the discussion, some of the things we're thinking about around recovery. And a lot of these interventions are the same things that we pursued to build capacity to deal with surges during the crisis. But some of the things are, maintaining digital access to care so that more people can be seen quicker and easier where that's possible and appropriate. Different approaches to waiting list management, so a lot more proactive understanding of who are those 5.4 million patients waiting now, and are there patients who have been waiting for a long time but might be better served elsewhere, so maybe not in hospital but in community care, and can they be shifted elsewhere so that they can get care quicker. And one benefit of having such a centralized, coordinated health system is that there has been more focus on collaboration and coordination and ability to share things like data so that we can better capacity plan and see how patients and resources can be allocated to be more as efficient as possible and see as many patients as we possibly can. And things I mentioned, like the private sector, those relationships are going to likely continue as we rely on that extra capacity and the NHS moves more patients into these private hospitals similar to Japan to be able to deal with some of the elective backlog for us. And lastly, using our existing staff as much as possible to do things like extend clinical hours and doing more work on nights and weekends to just, see as many patients as possible and get through that enormous waiting list that we're now experiencing. But of course, there's a lot of challenges and tensions that brings up and how to do that well. A lot of these maybe we'll talk about in the discussion, but I think just to say that COVID's not over, of course, and there's a lot of it still in the community. So while there's a pressure to do as much as we possibly can, there's still infection control measures and things that have to be in place to maintain safety, things like PPE requirements and spacing of appointments. And there's now just a balance, like as more patients and staff are vaccinated, like how do we think of that risk? But that's definitely a live challenge that we're now having to confront that may be similar in Japan. And there's just always, this is a constant tension, but it's the one of how do we focus on getting through that immediate challenge of the backlog, but not give up on kind of the long-term challenges and pressures, and a lot of which were also magnified by the pandemic. Like, so for example, when there's such an emphasis now on the surgical wait list in hospital care, we can't do that at the expense of not thinking about primary and community care, which are also core to our system capacity. But when there's only a limited number of resources, how do we best allocate them, and what will make the biggest difference to both our immediate and long-term goals? And then I think lastly, and that connect to that point is workforce. We also have workforce constraints that we entered the pandemic with. Staff have now been through a tremendous amount of stress, and we're asking more of them. How do we do that without making our workforce crisis even worse by burning out staff and not being able to retain the people that we really need to? And I'll just close in saying, Dr. Sakamoto had some really helpful OECD charts, and this is just a very busy table. That's probably hard to understand, but reflecting a similar message. But just to say that, to reinforce the point that the UK entered the pandemic with a lot of challenges that are now playing out in our recovery. And compared to a lot of our European neighbors, for example, we had fewer nurses and doctors per population than a lot of countries. We had fewer beds. We ran our system a lot hotter, meaning that we had much higher occupancy rates. So when there was a shock or challenge in the system, we just had a lot less flexibility to react to it. We also spend a lot less on capital in hospitals than other countries as a share of our GDP, meaning a lot of staff and parts of the health service are working with outdated equipment, which is important, and it makes it hard to get ahead of the backlog in the way that we might need to. So I think just want to emphasize that the challenges we're seeing in recovery weren't something that was born out of COVID, but existed before it. And it's not necessarily because of anything the health system is or isn't doing. It's really due to where we started from. And I will now stop sharing my slides, and great to get into the discussion.